Is anybody else coming? It's early in the morning, right? Can you? Does it work? No. Okay, you can hear me. So today we are going to continue cardiac physiology. Uh, Especially, there will be some review of the conduction system and the action potentials, and it never hurts to repeat because it's not easy to to memorize. But uh, we will also talk a little bit more about the mechanical activity of the heart and pumping function, and uh, what influences the function of the heart as a pump. Specifically, talking about the preload and afterload. I think you will discuss these things also during the small sessions today, right? If I understand correctly. So you can, and again, I know I don't want this to be more informal. So if you have any question, just raise your hand and ask the question. Um, so let's review the cardiac anatomy. Uh, Heart has four chambers and two main veins going to the right atrium, which is the superior vena cava, inferior vena cava. Uh, the right side of the heart pumps the blood to the pulmonary circulation, and the left side to the systemic circulation. Uh, the We have four valves, right? Three are have three cusps, and only the mitral valve has two cusps or two leaflets, anterior and posterior leaflet. So the circulatory system, there are three components. Heart as a pump pumps the blood to the body and establishes and keeps the pressure gradient that is necessary to deliver oxygen and nutrients to the tissues. Uh, the There has to be pressure in that system, and there has to be pressure gradient. If patients come with low blood pressure, they are in shock, which can be for several reasons. They the heart as a pump is not able to deliver enough nutrients and oxygen to the periphery, and patients have symptoms from due to cardiogenic or other types of shock in terms of uh, ischemia of the different tissues, and it can lead up to multi-organ failure. So it's important for the heart as a pump to maintain that pressure and the pressure gradient. And through the blood vessels, um, the the blood vessels, it's a complex and long system. I think I mentioned it in my first lecture. 120 kilometers of blood vessels. Uh, so it is really efficient pump to keep the whole life. The pressure in these vessels, and blood pressure physiologically can increase or decrease. It is not only pathology, and obviously, uh, with the age, when the vessels or arteries are less elastic, in some patients or in some people, the blood pressure, especially the systolic blood pressure, increases. But that's another topic, blood pressure and blood pressure regulation. We're not going to talk about the blood pressure today. And the blood as a transport medium. So, three basic components of the circulation system. Um, as I mentioned, heart separates the pulmonary and systemic circulation. Changes in contraction in the rate, which we talked about this bradycardia versus tachycardia, and the force of contraction, contractility, uh, changes based on the need of the body in terms of delivering either more or less uh, cardiac output to the tissue. Now, in normal physiologic state, there, as I mentioned, there are two main circulations, which in congenital diseases can be disrupted and is not physiological. Uh, Pulmonary circulation, again, delivering the deoxygenated blood to the lungs, where the carbon dioxide is expelled and the oxygen uh, uh, is delivered to the blood, and oxygenated blood goes through the pulmonary veins, right? How many pulmonary veins we have? Four, left and right, upper and lower pulmonary vein going to the left atrium, and carry the oxygenated blood to the through the aortic valve and aorta to the body. This is um, the pulmonary system is a low pressure system. What is usual normal pressure in the pulmonary circulation, the pulmonary arteries, which we measure by doing right heart catheterization? In the pulmonary circulation, it's less. It's in the millimeters of mercury, right? So it's a low pressure system. That's why we talked about the crescent shape of the right ventricle, and you can see the right ventricle, the wall is thinner because the right ventricle doesn't have to generate that much pressure. So what is the normal uh, pressure in the pulmonary circulation? When we measure the, in the pulmonary artery pressure, 60 millimeters of mercury would be classified as moderate to severe pulmonary hypertension, systolic pressure. 50, 15. It's yes. I mean, it's a little bit more. It's around 20, 25 systolic and 20 millimeters mean pulmonary pressure. So it's between 20 to 30. So usually the upper normal is like 30 millimeters of mercury systolic pressure. What about the systemic circulation? That's normal blood pressure that we measure, right? So it's 4 times higher. Around 120 over 80 is normal blood pressure in the systemic circulation, and that's why the left ventricle is much thicker to generate and maintain the pressure in the left sided circulation in the body. So this is again brief depiction of the system. Um, the cardiac output is or the with the cardiac contraction, the blood is expelled through the aortic valve to the aorta and then to the small arteries in the body. The brain, which is a small organ, but do you know how much cardiac output is delivered to the brain physiologically? Yeah, so 15 to 20%. So the brain or the part of the blood that goes to the neck and the head is 15 to 20%. So it, it it's a very metabolically active organ. So these are the major properties of cardiac muscle. Excitability, we talked about it yesterday, right? Being able to generate the electrical impulse. Conduction system to conduct the electrical impulse through the myocardium. Contraction, which is the mechanical activity of the heart. We will talk about it later. We yesterday and we'll talk about it today also. Refractory period, the cardiac muscle cells are able to and the refractory period is different between the skeletal muscle versus the cardiac muscle. I'll show you the slide. uh, Functional syncytium, you know what that is? So hmm? Yeah, so the heart has to work as a unit. The heart has to be synchronized. The heart has to squeeze at the same time, the right ventricle and left ventricle, and the, if there is a desynchronization, which can be caused by even simple mechanisms, either by um, decreased cardiac function, mechanical function in patients who have cardiomyopathy or simple conduction abnormality, especially left bundle branch block. There is a desynchronization of the heart. And what happens, for instance, in patients who have left bundle branch block? The electrical impulse goes initially to the right through the right bundle, and then it transfers to the left side of the heart in patients who have left bundle because they are not able to conduct through the left bundle, the anterior and posterior fascicular block. So you know what happens? So there is a desynchronization, and what happens, especially in the septal area, instead of in the systole, instead of the septum squeezing at the same time, contraction, it's called paradoxical septal motion. So the septum goes the other way towards the right ventricle, and the other walls of the heart are go in and squeeze. So this is called cardiac desynchronization, and it's important clinically because we use resynchronization therapy, especially in patients who have cardiomyopathy, who have weak heart. We put specific type of pacemaker wire through the coronary sinus to the lateral wall of the left ventricle, and we try to resynchronize this motion again of the heart, which improves uh, cardiac function, but also patient symptoms. So that's why functional syncytium is important. So the heart squeezes, all the walls squeeze at the same time. Autorhythmicity is heart is able to generate its own uh, uh, electrical activity. And then the staircase phenomenon, which is, you know what that is? So with each, if there is an increased contraction, or increased if there is an increased number of electrical impulses, there is an increased contraction of the heart. So basically like staircase. So if you have more impulses going to the heart, there is an increased contraction. So excitation, electrical event, we talked yesterday, primary responsible ion is the calcium, right? It's not the sodium, it's not the potassium. uh, we talked about the conduction and action potential propagation. We'll talk about it a little bit later. Um, so refractory period, we discussed yesterday too, right? What are the two types of refractory period? Right. So the absolute is there is no stronger electrical impulse that can generate another one, right? Unless you do defibrillation. And the relative refractory period is uh, the higher energy impulse can generate second impulse. So the absolute refractory period lasts 0.25 seconds. It's longer. The relative refractory period is only the portion of that, and it's only 0.05 seconds. Um, and we talked about the functional syncytium, autorhythmicity, and staircase phenomenon. So this is the cardiac muscle cells. This picture shows um, the types of cells. There are two types, right? Autorhythmic, or we talked about the pacemaker cells, is the same thing. So pacemaker cells, autorhythmic cells, same thing. It's the minority of the cells in the myocardium. It's less than 2% are the autorhythmic cells. Uh, these cells, they have the membrane potential that is called pacemaker potential. There is no resting potential because these cells, they need to continue generating electrical impulses. And then the myocardial contractile cells, which has different, they have different action potential, and they have the resting potential. Um so the How is the impulse um, to basically create this functional syncytium? The impulse has to goes through the muscle cells very quickly, and there are so-called intercalated discs. I think did you learn it in the anatomy? Yes or no? So intercalated discs that allow the branching of the myocardium. It's like connection of the myocardial cells, and then the impulse transfers through the gap junction. That's why there is a faster conduction of the impulse uh, to basically cause this uh, um, synchronization of the contraction of the cardiac muscles, and that's different compared to the skeletal muscle cells. So again, I mentioned contractile cells. 99% of all cardiac muscle cells are the contractile cells, uh, and they do the mechanical work, the pumping function of the heart. Um, and the autorhythmic cells, less than 2%, they don't contract. They are responsible for initiating and conducting the electrical impulse throughout the myocardium. This is called the excitation contraction coupling, which the electrical activity from the autorhythmic cells is converted into the mechanical activity of the contractile cells. So excitation contraction coupling is the term. Um, all right, you all know the electrical conduction system, right? We mentioned it several times, sinoatrial node. Um, we talked yesterday about the internodal pathways, how the impulse is conducted through the atria, and then there are this called Bachmann fibers. Uh, I think we talked about it briefly yesterday. These are the fibers that conduct the electrical impulse from the right atrium to the left atrium. So internodal pathway and the Bachmann fibers, and then you all know this AV node is bundle and two branches, right bundle branch and left bundle branch, which has two branches, anterior and posterior, and then Purkinje fibers, which is the final conduction of the electrical impulse to the myocardium. Uh, Now I put this picture. This is the skeleton of the heart, or fibrous skeleton, which is formed by fibrous tissue, which basically doesn't allow to conduct the impulse outside the AV node. So it is formed by the annulus of these valves, tricuspid, mitral valve, and the pulmonic and aortic valve. So there is an annulus, and then there is also fibrous tissue in between. So there is no possibility of conducting electrical impulse unless patients have this called accessory pathway, which we discussed yesterday. And we talked about this briefly 2 days ago. Normal rates in this sinus node, the AV node, the rate is lower, and in Purkinje fibers or in the ventricles, the intrinsic rate is even lower, usually in between 30 to 40 beats per minute. Uh, we are now discuss the conduction system and the action potentials again. I think this will be review, right? You will tell me what these channels mean. Um, Autorhythmic cells, again, initiation of the action potential. They have drifting resting potential. They don't have stable fixed resting potential, and this is called pacemaker potential. So it drifts. The pacemaker potential, the membrane slowly depolarizes to the threshold, which is around what? -40, right? So what are the channels responsible for that? Review from yesterday. Funny channels. And then, hmm? T-type voltage-gated calcium channels bring the potential to the threshold, right? And then after that, it's all here, which is a more influx of the calcium inside. And then the calcium channels close. And then, so that's called the polarization, right? And the second phase is what? So that's, yes, that's correct. Um, so this is the same picture, same diagram. Um, so these pacemaker cells have different type of action potential compared to the mechanical cells or the myocardial mechanical cells. And these are the contractile cardiac cells, cardiac myocytes that are responsible for the contractility of the heart. Uh, Resting potential. Hmm? Phase 0. What channels? Causing rapid depolarization, sodium channels, right? At the end, which is around plus 20 millivolts, the sodium channels close. And then, okay, calcium channel close after the plateau phase. And then this rapid depolarization is caused by potassium channels, right? And again, like we discussed yesterday, this is important for electrical or using different antiarrhythmic medications, which uh, has or they have effect on different cardiac channels. I think we can skip this one. So there is a longer action potential in the cardiac contractile cells. Uh, it's important to have this longer action potential. So there is a coupling of the excitation contraction. If there is not enough electrical or not enough long electrical potential, there is not enough time for contraction, and that's why the pumping function of the heart would be impaired. And it is the same with the refractory period, which is different compared to refractory period of the skeletal muscle. So the refractory period in the uh, contractile fibers lasts almost the whole uh, uh, time of the action potential. So this is the electrical activity, action potential, and this is the cardiac muscle contraction, which peaks a little bit past the plateau or at the end of the plateau phase, and muscle relaxation. And you can see very long refractory period. This will show you the comparison of the refractory period of the skeletal muscle. You can see how short is the refractory period of the skeletal muscle. And why is it why the skeletal muscle has short refractory period? Hmm? Yeah, it doesn't have the plateau, but why physiologically? So if there is repeated stimulation of the skeletal muscle, the muscle can can cause a continuous contraction. you cannot have, or you shouldn't have, continuous contraction of the cardiac muscle. The cardiac muscle contracts and relaxes. That's the function, that's the pumping function, compared to the skeletal muscle, because you can maintain contraction with repeated electrical stimuli. And uh, the refractory period of the skeletal muscle is it's very short. This is comparison again, action potentials between the skeletal muscle, uh, contractile myocardium, and the autorhythmic myocardium. So the membrane potential of the skeletal muscle is stable at minus 70 millivolts compared to the myocardium, which is a little bit lower, this minus 90 millivolts. And unstable pacemaker potential usually starts around minus 60 millivolts. So there are different numbers of the uh, membrane potentials. Different channels that are responsible for the depolarization. Um, I think we don't have to talk about this all detail. We talked about it several times. So the electrical signal flows through the conduction pathway, starts in the SA node, transfers through the atria, through the AV node, to the ventricles. Um, this is another picture that will show the electrical conduction of the heart and the depolarization. So when the SA node depolarizes, initial transfer of the electrical activity starts in the superior and posterior portion of the right atrium, and it's transferred through the atria, through the internodal pathways and Beckman fibers. And initial polarization of the septum in the ventricle, it's important. It's reflected on the EKG by what feature on the electrocardiogram. What do you see on the electrocardiogram? That is the initial depolarization of the septum. P wave. The P wave. It's not the P wave. P wave is reflected by the depolarization of the uh, SA node in the atria. So what do you see on the EKG, uh, especially in the precordial leads, V4, V5, that reflects the initial depolarization of the septum? Q wave. Yeah, it's a small physiological Q wave that is responsible for or reflects the uh, on the surface EKG reflects the initial depolarization of the septum, and then the impulse spreads throughout the right and left ventricle. So we talked about the electrocardiogram. I think we can skip. How much time we have? Half an hour. All right, I will skip these. These are the different heart rhythms. Atrial fibrillation, ventricular fibrillation. We talked about the uh, fatal outcome in patients unless they get defibrillated. So, cardiac cycle. We haven't talked about the cardiac cycle. Heart, basically, it's a two synchronized pumps in the heart that work together. Right and left side. Right side pumps the heart to the pulmonary vasculature, and the left side to the body. Um, Repetitive contraction and relaxation is responsible for cardiac output or stroke volume. Um, and as I mentioned, blood moves from the area of the higher pressure, which is which is created by the heart as a pump and closed system, closed circulatory system to the area of a lower pressure. Now, what are the phases of the cardiac cycle? Initial phase of the cardiac cycle is ventricular filling. What happens when there is a filling of the ventricles? What happens with the valves? Which valves are open? The AV valves, right? Which is the mitral and tricuspid valve. So AV valves open, and what happens with the blood? We said that blood moves from the area of the higher pressure to the area of the lower pressure. So the atria are filled with the blood. There is an elevated pressure in the atria. So when the valves open during the initial ventricular filling, the blood flows through the opened valves to the left and right ventricle. At the end of the diastole, there is an atrial contraction, which pushes the uh, more or blood from the atria to the ventricle. The next phase is the isovolumic contraction phase. What happens during this phase, the isovolumic contraction phase? So it's isovolumic, right? So the volume doesn't change, and the valves, all valves are closed, right? It starts off. So the initial phase of the systole, ventricular systole, the valves are closed. The pressure inside the heart increases because of the contraction, and the increased pressure causes what? When the pressure is increased and the valves are closed, what happens? So the higher pressure, higher increasing pressure inside the ventricles basically mechanically opens the aortic valve and the pulmonic valve, and that's the isovolumic contraction phase. When these valves are open, the mitral and tricuspid valves are closed, and the blood is ejected, which is called ventricular ejection phase, and the second part of the ventricular systole, and the blood is ejected to the pulmonary vasculature, which is the low pressure circulation, and to the uh, systemic circulation, which is the high pressure circulation. And then what happens after? So, so when the heart ejects the blood, it doesn't eject the whole volume. We'll talk about it. There is only part, uh, the stroke volume is only part of the blood volume that is ejected to the heart. What happens after that? So the, what causes, so that when the blood is ejected, what happens with the pressure? That's right. So and that causes what? Again, it's all about the mechanical activity, about the pressures. So the pressure is higher in the aorta and the pulmonary vein. So that causes what? What happens with the valves? Valve is open, now they close because the pressure drops. So there is a higher pressure in the aorta and the pulmonary vein, so it causes closure of the aortic and pulmonic valve. And that's the last phase, which is called what? isovolumic relaxation, right? So the volume doesn't change and the valves are closed. It's the initial part of the early diastole. And what happens after that? Basically, the whole cycle is repeated. Increased pressure inside the left and right atrium opens the mitral and tricuspid valve, and the cycle repeats. So it is important, this is really important to know all these phases and the mechanical activity, what happens with the valves. Will I will show it to you on several different slides so it's clear. Uh, Again, one more depiction. Uh, what is this phase? Is it ventricular filling, right? Because you can see the valves, the aortic, the mitral and tricuspid valves are open. End of the diastole, there is the atrial systole, right? We talked about it. What allows the atrial systole in terms of conduction? AV node does what? Allows the contraction of the atria to do the filling, the final filling of the ventricles, right? And then the isovolumic ventricle contraction. Again, you can see the valves. Do you see the aortic valves here? Here, aortic and pulmonic valves are closed. All valves are closed. Isovolumic contraction, and then ventricular ejection when the valves, the aortic and pulmonic valves are open, and isovolumic relaxation phase is the last phase of the cardiac cycle. All valves are closed until the pressure in the atria increases and opens the interventricular valves, mitral and tricuspid valve. This is the very nice but very complicated diagram. Have you seen this Wiggers or Wiggers diagram? It is basically, it depicts the whole cardiac cycle, what happens with the volume, pressures, uh, what is reflected on the electrocardiogram, and also the heart sounds that correspond to different phases of the cardiac cycle. What is the isovolumic contraction phase? Here you can see the left ventricle volume. So let's start from the beginning. Initial filling of the ventricle, increased volume in the ventricle, and this is the isovolumic contraction phase when the volume doesn't change. Now, what is reflected by the first, or what when you hear the first heart sound, which is the S1, what is um, cause, or what causes the first heart sound that we can hear when we listen to the heart? Closure, right? Closure of the mitral and tricuspid valve. And then um, the volume in the ventricles decreases, but the pressure, and I'll show you, the initial pressure volume loop, the pressure uh, increases, which opens the aortic valve, and then the ejection phase starts until the pressure inside the ventricle is lower compared to the pressure inside in the aorta, and causes closure of the aortic and pulmonic valve. By the on the examination, it's reflected by the second heart sound, which has two components, right? The pulmonic and aortic component. Um, and there is this called dicrotic notch, which is uh, decreased pressure due to closure of the aortic valve. And then the isovolumic relaxation phase starts. All valves are closed. The volume in the ventricle doesn't change because the valves are closed. And then the ventricular diastole starts when the interventricular valves open because of elevated pressure, higher pressure in the right and left atrium compared to the ventricle. And the whole cycle repeats again. Yes. You mean these lines? This is the aortic. This is pressure. This is pressure in the aorta. This is atrial pressure. This line. And this is pressure in the ventricle. Is that clear? Um, all right, I think we can skip these. We mentioned, the ventricle atrial systole, ventricle atrial diastole. Uh, so the left ventricle ejects about 70 milliliters of blood into the aorta, um, and the right ventricle has to eject similar amount of blood to the pulmonary vasculature. The volume that remains in the ventricles is about 60 milliliters, and it's called end systolic volume. So stroke volume is defined by end diastolic volume, which is the volume of the blood at the end of diastole after the atrial contraction, minus the end systolic volume. So 130, generally in the normal physiological resting conditions, 130 minus 60, it's a 70 milliliters stroke volume. That's again amount of blood that is ejected to the circulation. Diastole. All right, the normal physiological pressure volume loop. You know all this, right? So what is on the x-axis? X-y axis, it's called pressure volume loop, right? So the x-axis, it's left ventricular volume. The y-axis, left um, ventricular pressure. There are different points A, B, C, D. What is point A? So that's the lowest volume in the left ventricle, right? So what happens with in point A? Point A. So it's the end. Well, yes. The isovolumic relaxation is here. Is the end of the isovolumic relaxation. So point 8, I think you mentioned it, right? The initial phase of diastole, right? So there is a lowest volume and lowest pressure in the left ventricle. Pressure is low, volume is low. Mitral valve and tricuspid valve opens. So it starts, ventricular filling starts, and at the end of the ventricular filling, during the atrial contraction, the pressure rises to point B. The volume is increased because of the filling of the left ventricle and right ventricle. There is an atrial contraction which causes increased pressure, and at the end of diastole, during the end of ventricular filling, it's called end diastolic volume, right? It's the highest volume that is in the left ventricle and right ventricle. And that's point B, end diastolic volume. Then what happens? What is this phase from point B to point C? Hmm? So you see the volume doesn't change. But what changes? Pressure, right? From around 20, depends on the loading conditions, to around 80. So what is this phase called? Isovolumic contraction phase. So from point B to point C, volume doesn't change, the pressure increases inside the left and right ventricle. So that's called isovolumic contraction. What about point C to point D? That's the ejection, right? What happens with volume? Volume decreases, right? From like 130 or 135 to 60 or 65. So there is significant decrease of the volume because of the ejection, and it's the stroke volume. Uh, so at the end of the ejection phase, which is point D, is the end systolic volume. So whatever was ejected to the body is the stroke volume. Whatever volume was left in the left and right ventricle, it's called end systolic volume. So the pressure is still elevated. And then suddenly the pressure drops, but volume doesn't change. And that's the last phase, which is what? Isovolumic, because the volume doesn't change. Isovolumic relaxation. And again, the cardiac cycle starts again. So diastole, passive filling of the left ventricle, and then active filling by the atrial contraction slowly increases the pressure, and diastolic volume at the end of diastole. Pressure starts rising suddenly, but the volume doesn't change from point B to point C. When the pressure is elevated, aortic valve opens and the blood is ejected to the aorta and pulmonary vasculature. The amount of blood or the volume is called the stroke volume, and whatever is left in the left and right ventricle, it's called end systolic volume. And then pressure suddenly drops without changing the volume, which is called the isovolumic relaxation phase. Is that clear? So I just did it slowly so you understand. And so this is the normal physiological pressure volume loop. Tomorrow we'll talk about the cardiac valves, and we'll we'll talk about how these pressure volume loops change uh, in different valvular conditions. Now we talked about the heart sounds. We don't have to discuss it, about the physical exam. Uh, what is the cardiac output and cardiac reserve? So we mentioned stroke volume is the amount of blood that is ejected during the one cardiac cycle. What is the cardiac output? Amount of blood that is pumped by each ventricle in 1 minute. How do you calculate? Very simple, right? It's a product of the heart rate and stroke volume. So how do you calculate the cardiac output? Heart rate, yes. So stroke volume times heart rate. Uh, the higher heart rate, the higher cardiac output. The higher stroke volume, the higher cardiac output. We talked about the athletes who have slow heart rates. Uh, what hap- what happens in athletes in resting condition? So what happens? Yes. Why? So what's responsible for the elevated stroke volume if there is a low heart rate? What happens mechanically when the heart rate is low? There is a increased time for filling of the ventricles, right? With these slow heart rates, and but they are still able to generate uh, the same cardiac output because they have higher stroke volume. So if there is a increased volume, the cardiac muscle cells are more stretched, uh, and we'll talk about the Frank Starling curve. Uh, so these athletes, they are able to generate higher stroke volume at the lower heart rates, and that's why they don't have any symptoms even if they have low heart rate in the 30s and low 40s. So that's normal physiological mechanism uh, in trained hearts. And cardiac reserve, it's a difference between the resting and maximal cardiac output at maximal conditions, uh, especially when we uh, elevate, or the body elevates the heart rate by normal physiological mechanism, uh, which is the exercise. So the resting and maximal cardiac output uh, is the cardiac reserve. What happens with cardiac reserve when you age? Why? You're right. Why is cardiac reserve decreased? So with the aging, the people are not able to achieve maximum heart rates as high as. So when you get older, the maximum heart rate is not as high as when you are younger. Do you know how we calculate the maximum heart rates or predicted maximum heart rates? It's based on the age, 220 minus age. So when you are older, the maximum heart rate is lower. That's why the cardiac output, maximum cardiac output is decreased, and that's why cardiac reserve is decreased. Uh, Factors that affect the cardiac output: autonomic innervation. We talked about the sympathetic and parasympathetic nervous system. The hormones, epinephrine, norepinephrine, even the thyroid hormone, they increase contractility, increase the heart rate, they increase the cardiac output. Uh, Stroke volume is affected by the Frank-Starling law. Um, I mentioned it, the more stretch of the cardiac fibers causes more vigorous cardiac contraction. I will show you the image. And then venous return, same thing. If there is elevated venous return, there is a elevated um, stroke volume because of increased stretch in the myocardium. I think we can skip these. It's almost 9. Yeah, that's what I wanted to do. Um, so what is the preload? We'll just go briefly about it. I think we'll talk about it during this small session. Amount of blood entering the ventricle during diastole. So yes, so the preload is basically the higher preload, higher end diastolic volume, right? So the preload is basically um, the reflection of preload is the end diastolic volume. How do you increase the preload? In the left ventricle? Venous return, right? Increased venous return increases the amount of blood going through the right atrium and right ventricle, and then uh, 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 through the pulmonary vasculature to the left ventricle. So the preload uh, amount of the blood that is the ventricles are stretched by, and it's reflected by the end diastolic volume. So if you have high preload, there is a high end diastolic volume, and it increases by Frank-Starling curve uh, stroke volume. What is the afterload? Something that is after the the ventricle, right? After it. So what is the afterload? Yes, exactly. So that's the resistance that must be overcome. It's a pressure that is exerted by blood in the large artery, leaving the heart. So the higher the afterload, the higher work that the heart has to do to overcome this higher pressure. Uh, so how do we improve cardiac function? By increasing the afterload or reducing the afterload? Yes, reducing afterload, right? Improves the stroke volume because the heart doesn't have to overcome higher pressure or higher resistance. And again, preload defined as a force acting to stretch the ventricular fibers at the end of diastole uh, and diastolic volume. Um, the higher the preload, the higher the stroke volume. This is the Frank-Starling law. So the increased stretch, which is indicated by the end diastolic volume, increases what? it's increased by preload. Increases the stroke volume, right? Increases the contraction. So until the point when there is a plateau phase at the end, and at that time, so there is a limit. You cannot stretch the heart continuously and improve the stroke volume. So there is a limit, which is the plateau phase. When the volume reaches the plateau phase, the heart cannot increase the stroke volume anymore. So um, this is the typical Frank-Starling law. You should remember the curve. And again, this is the same thing. Um, this is the normal cardiac cycle, the rapid filling, reduced filling, and then filling based on the difference between on the difference pressures between the atria and the ventricles. Initial phase, rapid filling, uh, later phases, reduced ventricular filling, and then atrial contraction basically increases the volume inside the left ventricle, and by Frank-Starling law, increases the uh, stroke volume. That's why patients who are dependent on the atrial contraction, which are usually patients who have diastolic dysfunction, commonly patients who have aortic stenosis. If these patients lose the contraction of the atria that contributes to the ventricular filling, these patients start having symptoms. What happens when what arrhythmia causes the loss of atrial contraction? Atrial fibrillation, right? So clinically, patients who develop atrial fibrillation, if they are dependent on the contribution of the volume in the left ventricle from the atrial contraction, and again, these are patients who have stiff ventricles, patients who have hypertrophy of the left ventricle for several reasons. Valvular heart disease can be one of them. These patients who are dependent on the atrial filling, if they lose the atrial contraction when they develop atrial fibrillation, these patients can develop very rapidly congestive heart failure. Uh, so the last thing is the afterload. You mentioned it. Afterload is the resistance to the ejection of the blood from the ventricle. The higher afterload, the higher resistance, and the less blood can be ejected to the circulation. So uh, lowering the afterload improves the cardiac function. Increase in the afterload causes stroke volume to decrease. We have medications that are specifically developed to decrease the afterload. Uh, it is important to know that because uh, especially patients who have congestive heart failure, who have cardiomyopathies, we use these medications, different medications that either increase or decrease the preload and afterload. So to improve cardiac function, we want to increase the preload and decrease the afterload, right? I think I will stop here because it's 9 o'clock. Um, do you have any questions? I think we'll talk about these physiological functions of the heart, preload and afterload, and cardiac cycle in the small sessions. Thank you.